family history. There was no known significant family history. He lived alone, but was well supported by his daughter, who lived about 25 kilometres away, active smoker, minimal alcohol, and independent with his ADLs. So he went on to have a gamut of the fairly standard investigations, starting with an upper GI endoscopy, which identified a large ulcerated bleeding mass in the distal esophagus with a circumferential partial obstruction extending 30 to 35 centimetres from the incisors, with a biopsy confirming a poorly differentiated adenocarcinoma, MMR proficient, CPS 15 and HER2 negative. A CT chest abdo-pelvis was done, showing the distal esophageal lesion with suspicion of invasion into adjacent structures, with some lymphadenopathy above and below the diaphragm, and some possibility of non-specific left upper lobe pulmonary nodules. And he went on to have a PET just 4 days later, which again identified a very large esophageal mass, nodal disease, and then those pulmonary nodules were increasing at a fairly rapid rate. I appreciate it's a bit small on the big screen, but we can see the primary on the left and some nodal disease on the PET scan on the right. So that all took about 4 weeks. It's probably pretty standard, or maybe quicker or slower, depending on which centre you work in, but obviously with the hindrance of the Christmas, New Year period. So in January, he was seen in a medical oncology clinic, and based on his histology was commenced on first-line FOLFOX plus nivolumab. He developed a grade 1 rash after his second cycle of FOLFOX and nivolumab, and at this point, it was being seen every 2 weeks. The patient was seen and treated regionally, so it's not uncommon to have monthly reviews once they've stabilised on treatment, but he was still being seen every cycle, or prior to every cycle. So with the grade 1 rash, when he was seen, he was prescribed a topical steroid, which in hindsight he did not fill, but was advised to continue with treatment, which he had. And safety netted to inform the clinic through our nursing network should he have any worsening of his rash. He did not do that. He then presented cycle 4 and was noted at the day treatment unit to have a significant progression of his rash, with the blistering erythematous rash over his, well, largely his entire body, including his scrotum, and was deemed to be grade 3. He was also febrile to 38 degrees and hemodynamically stable, non-neutropenic. And so his infusion unit was not at the tertiary centre, so it was quickly arranged for him to be transferred to the tertiary centre, so he could be under the medical oncology team rather than a general medical team, with dermatology, with the intent of having a dermatology review. A punch biopsy was performed, and phone advice was received from dermatology by the DTU, junior doctor, for some topical steroids. I should note that dermatology said don't give systemic steroids at that point. He later that day arrived at the tertiary centre, was seen by the medical oncology team, and rapidly started on IV methylprednisolone at 1 milligram per kilo with the intention of having it for 3 days. That biopsy ultimately came back showing essentially a drug-induced dermatitis. I'm not sure, it sort of comes up on the screen. So this is just a indication of how he looked when he arrived at the tertiary hospital. I did not include any scrotal pictures today. So within 24 hours, he was seen by a dermatologist. They had significant concerns for rapid progression to TENS or Stevens-Johnson's. This was coming into a long weekend, and given the limitations of where the patient was treated, the plan was for an urgent ophthalmology review and transfer to a metropolitan hospital where they had a burns unit just in case. He ultimately completed 3 days of IV methylprednisolone, didn't require any further escalation. His treatment was transitioned to oral steroids at 50 milligrams daily, with the plan to slowly de-escalate over approximately a 6-week period, and was discharged directly back into the community from the Metropolitan Hospital with weekly reviews organised. The nivolumab was ceased indefinitely, but the plan was to continue with Folfox if he was well enough. Over the next 2 months, the patient had a slow wean of his prednisolone, but once he got down to 10 milligrams, had a significant increase in his rash back to a grade 2 or 3, with, at that point, re-escalation in his oral prednisolone. He also had mucositis and thrush. This was felt to be attributed to his cytotoxic chemotherapy rather than any immune-related event. And again, as he was weaning down, he got to 20 milligrams with a grade 1 rash, which then flared back to a grade 3. His prednisolone was then re-increased to 1 milligram per kilo, which was 70 milligrams. Dermatology were re-reviewed. They repeated a biopsy. So that's probably not the most profound photos, but this is what we could appreciate when he actually took his pants off. He was in a lot of pain as well, I should note. Yeah. So the second biopsy was done, and at that point the dermatologist came and said, oh, this is a psoriasiform dermatitis, which is drug-induced. And we were advised at that point in time, this is not best treated with systemic steroids, and if you wean the steroids too quickly, it can result in a flare in the rash. So they advised a topical treatment, very slow wean. Initially, they advised 5 milligrams per week in reduction, but he then got down to 15 milligrams, had a worsening in his rash again, and ultimately was planned for a 1 milligram reduction per week. He was also started on acretitin, which is the preferred treatment for psoriasis, and had this waxing and waning period on oral systemic treatment. Coincidentally, during this period, he had another PET scan, and he had a complete metabolic response to his treatment. And so after 6 months of chemotherapy, the decision was to put him on active surveillance. His rash was clinically improving, and he had ongoing dermatology inputs. They upped the ante. They started de-escalating by 2.5 milligrams every 2 weeks, with a planned cessation of steroids November of this year. He's still on steroids as of last night. So for those who are good at maths, he started steroids in March. A bit longer than 6 weeks.
Thanks, Michael. And thanks for logging on last night on EMR to make sure he was still on steroids. Can I ask a question?
I haven't finished.
Oh,
yes, you can.
What dose methylpred did you give him?
We gave 1 milligram per kilo.
1 milligram per kilogram, yeah. Is that what you, Steph, Chris, would have given as well?
I mean, if we needed to give IV, as a minimum, I'd start at 2 milligrams per kilogram. It's just what we do. I don't think anybody knows what the ideal dose is, and sometimes we pulse steroid where we give a significantly higher dose, 500, even higher, even 1,000. But yeah, and for my patients at least, we see skin toxicities relatively commonly. It's one of the most common, as we saw in the slides earlier. I would usually start with topical measures, as I think you did.
Tried to.
And most of the time that works. I mean, this is interesting because this was kind of a dry rash. I get particularly worried when I see blistering. So you can get bullous pemphigoid, and that's a really bad one. The dermatologists have taught me that, and that's where I really look at stopping the steroids and usually don't reintroduce And that's when we will go for higher dose steroids. But this is interesting because it's psoriasiform, it's different. And the treatment, as you pointed out, isn't usually steroids. You need to go with sort of something different. In this case, it was a retinoid that worked. It's really interesting.
Mm. And weaning, how do you wean your skin toxicities with the steroids, Steph? I find there's a big variability in practice. Obviously, it was a bit tricky.
Yeah, it depends. It sounds like you tried to wean, failed, went back up again. So we try. Depends on the severity of the rash as well. I think with this case, it was a bit delayed because you did try to start him on steroids. So maybe if we had started earlier, we potentially could have weaned him more successfully. But I would do the same. I would, there's no right or wrong. It's really, sometimes it comes down, if I do pred, it's pill burden, practical things like that. How many pills do you take? So comes in 25 and 5. So if you start at 2 milligrams per kilogram, which is what we tend to do as well. And then if they don't respond, we would pulse them. And then failing that, we would explore, steroid-sparing agents. And then I would usually wean by 10 or so per week, depending on the clinical picture.
Sorry.
Just another quick comment. Just for this patient at least, the impression I have was this patient may not have been the most compliant patient. So I think, good close clinical follow-up is important. It may not necessarily need to be the medical oncologist, but I'd certainly want to get the GP involved, and you've already got dermatologists involved. And if you've got, a nurse practitioner or a clinical consultant nurse that can oversee things and monitor the patient, just to keep them on track, because I think, this is turning into a chronic toxicity with long-term management, and so we need to try and improve that compliance.
For what it's worth, after his first flare, he was essentially seen weekly by the medical oncology or dermatology until now. So just 1-2 slides on immune checkpoint inhibitor-induced psoriasis or psoriasiform dermatitis. So it represents a very small percentage of ICI-induced skin toxicity, about 3%. And as mentioned in one of the previous slides, is generally refractory to systemic steroids, which is how we generally, after topical steroids with no improvement, approach these patients. And that's the challenge, I suppose, for us, because you treat the horse in the room, not the zebra. And there's always going to be those that behave very differently. And so the current recommendations for a psoriasiform dermatitis is topical treatments with the possibility of biologics, although this is much more complicated than just saying, we can throw biologics at these patients, with PBS requirements indicating for those that are available, firstly, there's no stipulation between ICI-induced psoriasiform rash and psoriasis idiopathic, but it has to be prescribed by a dermatologist. So I'm presuming there's no dermatologist here, so it's not actually within our scope of practice, and that's where embracing the expertise of our colleagues is very important. I think that we'll become much more comfortable with dealing with toxicities, and it may be common that we are the people with the most experience in certain situations, but there are always a role for, I suppose, embracing that expertise in different disciplines. And in respect to the use of biologics, this is a relatively new area. There is very little literature in terms of what to use, when to use it, and whether or not it has any impact on cancer control. Look, there is a number of sort of review cases. These are just a few that I managed to find last night, which sort of detail individual specialists or centres' experiences with the use of biologics. So it's more of an indicator of where we may be headed, with a small percentage of our population experiencing these toxicities, but certainly probably isn't the standard at present. And so our current EVIQ guidelines, which a lot of people use in Australia, and sort of junior staff often refer to when they're not sure what to do, not only in appropriate staging but also management. As we can see there, for grade 3 toxicity essentially indicates what was followed in this patient's case of, stop the nivolumab, give them topical treatments, and do a punch biopsy, get a dermatologist, give them methylpred and high-dose oral pred. But the EVIQ guidelines, just like the ESMO and the verbose ASCO guidelines, they don't sort of differentiate between the different skin toxicities that we may experience. So it's a sort of a one-trick-fits-all, or one-shoe-fits-all approach at the present. And that's, I suppose, up to us as the specialists to understand when something doesn't behave as we expect it to. We have to think beyond our guidelines. Thank you.
Fascinating case. I must admit I would have reflexly high-dose steroided this patient as well. Question to my colleagues. I remember you said he had some thrush and mucositis, which was attributed to the chemo. Definitely not the prolonged steroid use contributing.
Well, certainly the thrush, we did say, was in the context of the long-term steroid use. I suppose it was more the mucositis. I think in hindsight, maybe a little bit more thought could have gone into that, given the skin toxicity, to ensure that it wasn't immune checkpoint inhibited, but he was on oxaliplatin and fluorouracil. It looked very much like what we would normally see, and it responded to pretty standard treatments. So that was the only other toxicity experience. So.
Any other steroid complications? He was on steroids for, over 6 months, 8 months. My maths is terrible.
Well, I admit, his habitus looked a little cushianoid before we started, as you could see. So, no, just a lot of skin thinning.
Was he also on PJP prophylaxis?
Yes,
yeah.
I should have mentioned that.
Yeah.
PPI and PJP prophylaxis the whole time.
Question
no Bactrim rash.
No Bactrim, yeah, no Bactrim rash. Phew. Question to Chris, Steph. Do you at baseline check Hep B, Hep C, HIV? Some of our patients who that small, 10%, 20% with doublet who might have a severe toxicity, might need long-term steroids. We're now facing that more commonly, and I think we are sometimes now running into unexpected long-term toxicities of steroids. I'll ask you a question about that later, Bruce, as well. What baseline tests do you guys do?
So of all tests, so I guess baseline blood tests, the usual thyroid function, cortisol, sugars, HbA1c, I note, is on the EVIQ protocol. I have to say I don't always do it, but I guess many patients are also diabetic. In terms of Hep, HIV, etc., I'd say I'll do it for my high-risk patients. I don't do it in everybody.
Neither.
And that's the same case with chemotherapy.
We've embedded Hep B screening pre-cancer treatment. It's obviously pre-chemo. So everybody pretty much gets a Hep B surface antigen core antibody test just to check for the presence of hepatitis B or actual viral kind of exposure to virus previously. But we don't, as a routine, do HIV unless they're a high-risk case. And maybe we should, or at least maybe we should consider it when we get a patient like this who's going to go into long-term steroids for immune toxicity. And we don't routinely screen for hepatitis C either, but maybe we should. If I could just go back to this issue, a really important kind of consideration that we have as clinicians, prescribers, around trying to distinguish toxicities and attribute causality to IO or chemo. So as in the case that we've just heard, the patient's receiving chemotherapy and immune therapy, and sometimes it's a challenge. And I remember a case of a patient who was receiving the same regimen of Folfox with nivolumab, and they were managing it quite well, had a really good response, and then they developed mucositis after quite a number of cycles, and it looked, for all intents and purposes, like 5-FU-induced stomatitis mucositis, which is a common toxicity. We see it all the time. The strange thing was that it wasn't happening at cycle 1, it was happening at cycle 8, and it the dose hadn't changed. And so I did the classic thing of not giving him 5-FU, but continuing the Nevo, thinking he still had 5-FU toxicity. It panned out that was the bad decision.
It was the culprit.
Because it was nivolumab's fault. So he had an immune therapy-induced stomatitis and ulceration.
Esophagitis?
Yeah, kind of went. So So it is really hard, I think.
Absolutely.
So you need to think carefully, and sometimes it's sort of a, weighing up the chances. You're making a clinical judgment, which can be difficult. Yeah.
Absolutely. I also find it tricky to necessarily predict which patients will get the toxicities, the long-term toxicities necessitating steroids. I don't think you can always, your patient, Michael, didn't have any baseline autoimmune diseases or any major red flags that, I would have necessarily considered. Bruce, I guess I find it often quite hard to consent. So just for the audience, I had jokingly said we would get Chris to consent for doublet IO on this presentation.
I was practicing my acting skills. I was thinking, I do this every day. It's not acting. I do this every day. But if I was going to do it in front of you, I wasn't going to do it the natural way. I don't think. But anyway, let me off.
Bruce, how do you think, clinicians are at consenting for, immunotherapy? There's, on EviQ, when we give you the handout, there's 4 million potential things, bad things that can happen under the sun.
Well, you don't have to ask me what I think clinicians are like in terms of consenting for immunotherapy. Clinicians are exactly the wrong people to consent anybody for anything. Now, and there are several reasons for that. One is that most of you are very bad communicators anyway, but I wouldn't say that. But you live in a different world to us. Okay, I should point out that I've had 2 oncologists, the best 2 in the world, so they don't count. But the other thing is that most patients, and I have to take myself out of this category as well, they are in awe and scared of you, and they will not ask the questions that they need to. And I'm sure you all know, when the patient leaves your surgery after the first discussion, they'll remember nothing but the word cancer. And they will then try to please you in terms of signing an e-consent form. I also have a view, if I could be so bold, and really it's got nothing to do with immunotherapy, I personally believe that the e-consent forms that we use at the moment are completely not fit for purpose. They are basically setting out what the legal situation is for the patients. They spend forever talking about what the bad side effects will be and very little time talking about what the good can come from it. I'm not advocating they should disappear. I think there should be another form of explaining to them what a trial's going to have. So
Reasonable.
who should do the consenting process? My view is it should be somebody like a cancer nurse.
Yeah, I was going to say that importance of, that multidisciplinary team management. Absolutely. In the interests of time, I might move on to the next case, and I think we'll have a few more things to discuss as well. So, word of warning, this is a little bit of a roller coaster ride. So I met this 7-year-old man who presented with 3 months of dysphagia, unintentional loss of weight, gastroscopy demonstrated adenocarcinoma. Oh, thank you. Lovely. Thanks. Adenocarcinoma, baseline CEA and CA19-9 was normal. Had a diagnostic CT and PET scan, distal esophageal cancer, mediastinal lymph nodes, some celiac axis nodes as well. At that stage, at the MDM, it was thought the field was too extensive for definitive chemoradiotherapy. He received palliative radiotherapy, so 36 in 12, moderately high dose. And in retrospect, was the right decision because 3 months later, he had pulmonary and liver metastases. So, timeline-wise, June 2022, he started Folfox/Nevo on the BMS Compassionate Access Scheme. After 4 months, due to oxaloneopathy, went on to maintenance. Did pretty well for about a year or 11 months. Had an enlarging pulmonary nodule. We watched and waited, query, a little bit of whether it's a real solitary nodule or some reactive inflammation, but it continued to grow, and when we biopsied it, it was just a poorly differentiated non-small cell cancer, so we sabred that. And then about a year after that, he developed some increasing shortness of breath, decreased exercise tolerance. We made sure there was no PE, but there were features of bilateral pneumonitis, not just in the field that was sabred. So we treated him as an IO pneumonitis, oral pred, 1 milligram per kilogram, because he was still an outpatient and wanted to stay home with some Bactrim cover. And at this stage, he'd had finished his 2 years of PBS-funded nivolumab, so we actually ceased everything whilst he was on treatment for his pneumonitis. Wet pred was slowly weaned. We weaned a little bit more slowly, 5 milligrams over 5 days, possibly because we do a bit of melanoma in our centre, and our melanoma guys are just a little bit hesitant about severe toxicities now. Oh, hang on. Yes, there we are. Just a reminder, November 2025. No, that's not correct. Yep, no, sorry. So weaned slowly over 3 months. Should be November 2024, apologies, as a mistake, was when we ceased the Nevo. And then 3 months later, so early this year, we noticed his renal function was kind of slowly creeping off. And in retrospect, had been doing it for some time. But you know how when the creatinine kind of goes from, 80 to 90, then 100, then 110, doesn't look that different. You don't kind of realise until suddenly you look at the pre-treatment bloods, you go, oh my gosh, the EGFR is 20, the creatinine is 245, what did we miss? And this is whilst he was still on prednisolone for his pneumonitis. So we admitted him, we did screening IO bloods, and our screening IO bloods, even though he was completely asymptomatic, included a CK troponin, and his troponin came back at 852 with a CK of 1700. This is where my heart stopped, even though the patient's heart was still going. So we were concerned of immune-related myocarditis, nephritis, and his LFTs were off a little bit as well. We got our friends, the renal physicians, involved for their opinion. They thought it was drug-related, AIN, possibly immune-related nephritis. Aren't they the same thing was our question, but hey. They didn't do a biopsy because he's on a DOAC. We got cardiology involved who said it was potentially a type 2 non-STEMI. There was another name for it, I can't remember the acronym, and their second differential was immune-related myocarditis. And like when the dermatologist said we wouldn't give systemic steroids and then Onc went in and gave systemic steroids, we ignored the people that we'd asked to consult on and just said it's all immune-related adverse events. So we pulsed him. We gave him 1 gram, 1,000 milligrams. We pulsed him because of the myocarditis. And we changed his PPI to nazatidine because renal didn't like him being on a PPI. And we actually changed his Bactrim to dapsone as well. 1 gram of methylpred, too high, do you think?
That's
reasonable.
That's as high as I'd go.
Yeah.
That's amazing. I mean, I'm really inducing a significant rapid kind of immune-suppressed state, really trying to reduce that T cell activity as quickly as possible. And the reason here was because of the myocarditis. That's one of the worst, as we know, and the outcome can be very bad. So
I think our concern, as Steph mentioned earlier, is that the fatality rate can be quite high with myocarditis, and so we spoke to our melanoma colleagues and we just gave him a very high dose of methylpred. So admission 1, troponin started coming down, got him home at 100 of pred. Unfortunately, 2 weeks or 1 week later, his troponin went back up to 1,000, so we readmitted him. We repulsed 1 gram 5 days this time, not just 3 days, so lots of steroids now. There was a question of chest pain. We couldn't, CTPA was unable to exclude a PE, so just for progress, we changed into Clexane. Got him home for a few days, essentially, and then he was admitted again because his troponin went back up to 1,000. So he's now been off steroids since, it should be November 2024, but he's been readmitted already 3 times within 2 months, or 1 month and a half. So even though he'd only been home for 5 days we this time pulsed him at 2 grams per kilo, very, very high, and we actually added in IVIG and tocilizumab. I don't know if you guys have done much IVIG and toci in bad IRAs, but we were getting nervous. In between the day 1 and day 8 of the toci, we optimistically tried to discharge him on oral pred, but his troponin went up, so we readmitted him for methylpred again with his day 8 toci. I think there's something cut off, but essentially there's a line below that, but he was eventually discharged home after the day 8 toci with Yeah, with oral pred, and we actually started mycophenolate for him as well at that stage. Yeah, because his troponin started to improve. So now he's been essentially off Nevo since November, so 5 months off Nevo, and he came in feeling just a little bit unwell, vague. Repeat bloods, he now had a new pancytopenia. His kidneys had gone off again a little bit. His LFTs were a little bit off, but his troponin was good. Woohoo, finally. So, so this is where we added and mycophenolate. Apologies, my fault, I've forgotten. So we continued 100 of pred at that stage, and this is when we added mycophenolate, and we got heme involved for his pancytopenia. We were worried it was an immune-related adverse event. They thought it could be an oxidative hemolysis from the dapsone, which we changed from Bactrim earlier. He was now on Clexane because there was a question of whether he had a P and a DOAC, and whether it was HITS, was it disease? That's always a consideration. Heme did a whole lot of things. HIT screen was negative. Restaging showed ongoing response to treatment, which is great for him. And essentially they concluded it was the dapsone causing the hemolysis. So then he was changed to pentamidine, and we continued mycophenolate. And given his troponin was holding, we continued to slowly wean his pred. Admission number 6. He came in now having stayed out of hospital for a little while. We were very proud of him, with urosepsis, hypotensive shock, and he had an E. coli bacteremia at that stage. And then 2 months later, he came in with pleuritic chest pain. We were very worried about his heart. His troponin was actually pretty good, 100 to 200 only, and he ended up being flu A positive. And then that admission, he was quite fit until then. He really started to deteriorate. So he unfortunately then got a superimposed hospital-acquired pneumonia, needed HDU, and then he became more Cushingoid, like you were saying your patient was, Michael. Started to get some proximal myopathy, and sitting at being ICU, really needed some rehabilitation then, and that time he was in for a whole month. I wasn't as good as Michael. I didn't log on to EMR last night, but as of last month, he was still on slowly weaning pred, and our notes finally say in capital letters, not for further re-challenge immunotherapy. But luckily, his staging CT shows stable disease. I thought this was an interesting case, first of all, because it was a roller coaster for me and the patient. But I think every time his troponin went off, my heart stopped. But we were really running into problems of long-term steroid use as well, with an obviously potentially life-threatening immune-related adverse event. And I think particularly as his performance status declined, he kept on asking, can I have more treatment for my cancer with stable disease? He was very, very anxious about the cancer. I guess I'm just keen to my friends here on the panel, with these patients, long-term toxicities, survivorship, how do you guys manage these long-term patients? Because we are getting more and more of them. They're living longer, which is great from a cancer point of view.
It's a real challenge. I think, we've all got patients who receive immune therapy treatments and they get very little toxicity. Some, the worst they'll get is needing to get put onto Pyroxene, but don't feel anything. I don't feel any difference. And I tell patients there's about a 50% chance you probably won't feel any difference through this. You won't get nausea, you won't get vomiting, you won't get a bad rash, and you won't get any of these major organ kind of toxicities that we're seeing. But in the other 50%, you do get issues that need management, and in about 20%, I think those issues would be classified as severe, and in 5 to 10% potentially life-threatening. So these are significant numbers, and I'm going to sort of ask Bruce. How do you think kind of most patients, I know everyone's different, and as you said before, the way that information is kind of relayed across is different, but there's quite an extreme here. It's a bit different. With chemotherapy, I can explain they're going to lose their hair, and I know they will. With certain chemotherapy drugs, they're going to get numbness, and I know they will, and they know. And they're going to get low blood counts, and we know they will, and they know they will, and that's part of the deal. But there's quite a variability from almost nothing to in ICU, on a ventilator. And one of the real challenges with immune therapy is we can't predict the patient who's going to get the really bad reaction, or at least as far as I'm aware, there aren't really great predictive factors, but we need to explain these risks. So as a patient, Bruce, what do you think?
I suppose I should point out first that I'm to some extent an imposter. I have had colorectal cancer, but that was a long time ago. But about 2 years ago, I wasn't feeling well and had a bad cough. Went to my GP, said, I've got this bloody gastric reflux stuff again. It's making me cough. I can't actually keep things down properly. new GP, stupid idiot. The story changes in a little while. He decided that perhaps it wasn't gastric reflux, so I went for a CT scan. And I come back 2 days later, and there's a very sad-looking doctor in the room who tells me that I have metastatic tumours in the lungs, in the liver, in the adrenal glands, in the bones and everywhere else. And he was sure that it was colorectal cancer coming back again. But he's probably not here, but my oncologist was Steve Ackland, so of course it wasn't coming back. Luckily though, because Steve Ackland is now a friend, after a good deal of discussion, which wasn't particularly friendly between the doctor and I, who is now my friend by the way, we agreed that I would ring Steve up and talk about it. And Steve, of course, said, well, it could be, but probably not. It's going to be either lung cancer or melanoma. So then it was go and get a liver biopsy. Okay, so the first part was I went for gastric reflux. I ended up with the melanoma. Then I go to the next great oncologist because Steve doesn't do the immunotherapy. And it turned out to be melanoma that I had, right? So then I start on the melanoma treatment. Here's where we talk about the different experiences. About 2 to 3 weeks into the double IP and nivolumab together, I could no longer actually eat anything. I was coughing uncontrollably. I was in a really bad way. I talked to the oncologist and said, is it possible that this could be the gastric reflux problem being exacerbated by the immunotherapy? No, the response was, no, I don't think so. So the one really good thing that, one of the many good things that I'd say, in Newcastle, if you're getting immunotherapy, the one thing that you get that I think is really worthwhile is a piece of paper when you leave to take it with you that says, if you get a temperature or feel unwell, go immediately to hospital. And the thing says they've got possible febrile neuropathy, neutropenia. That's really good. So I went to the hospital, twice in fact, and get a good registrar who both times says, we go through the process to see whether I need to be admitted. Not quite that bad. Second time I said to him, because you may have not worked this out, but I tend to be a bit pushy. And I said, I will go through your tests if you will have a look and see whether the gastric reflux is causing the problem. He said, I don't know, but there's a gastrologist in the hospital. I'll get her to come down. Friday night at 7 o'clock, she walks into the room and I said, I just wanted to know whether the immunotherapy could be impacting on the problems that I've got with the gut. And her response was, of course. So the next day I was in getting the whole thing fixed and then I was fine after that, for that stage. So the first thing I'd say is be very careful that it's not something else. And my experience, which is over the last 2 years now, has been that what the immunotherapy does for me, if I get any kind of a problem, it is amplified through the immunotherapy. If I've had COVID in the process, and COVID was, the first couple of days were fine, and I got the antivirals, which I'm allowed to have, and things like that, but it was just awful and different to the other COVIDs that I've had. And I've had a few issues like that. So the different patients, the thing I suppose that I'd like to say about this is, my experience is that GPs, and this is a sample size of 1, know practically nothing about anything to do with immunotherapy. When I went back to the GP with the thing that said, his adrenal gland has stopped producing hydrocortisone, and I'd already talked to my oncologist, Andre, about it, who said, yeah, that's fine, we give you the high zone tablets. My GP was absolutely thinking I should be going and seeing a specialist immediately. Then I had to go back to Andre and say, what should I do? And if anybody knows Andre, which you probably don't, he's a lovely guy, he sort of looked and smiled and said, perhaps you should go and see a specialist after the treatment's finished to see whether he can get it restarted again. I think there's a lot of lack of knowledge. In terms of my journey through the process, yes, I've had the rashes. Yes, I've had stays and I've had the steroids. And yes, the steroids make you feel fantastic in an hour. But I've always wanted to get off it as quickly as possible. And other than that, immunotherapy, even with all of those problems, it's a ride in the park compared to chemotherapy.
You're right, though. I mean, getting our other specialties involved, there's a comment about getting our friendly dermatologists, but other specialists involved, educating them, ED, GPs, I think is really, really important. We're learning on this journey, but so are they. And I think particularly as we get more access to doublet immunotherapy and the toxicities get more complicated. There was a question on prophylaxis for PJP, which I was going to throw to you. When do you start PJP prophylaxis for patients on steroids? Michael, anyone?
Straight away.
Yeah. Same.
Yeah, so
I
if
normally
it's
think-
anticipated they're going to be on it for more than, a week, then start straight away, along with PPI.
Yep. Agreed. And following from that, we've come across a couple of stories now of esophagitis immune-related. Sometimes you can also get candidemia, which I find a little bit hard to differentiate the two. Do you ever consider fluconazole prophylaxis for these patients who are on long-term steroids as well? Get the gastroscopy first, see what's going on?
I don't do it prophylactically, fluconazole. I mean, obviously, if we detect Candida, then we look at fluconazole as a treatment measure, but I don't do it as a prophylactic measure. I've seen some write-ups that talk about it, and some people do it, but I don't. I don't know if the others, if you do fluconazole.
No, I don't, but I guess it's high up on in my mind, definitely. But I don't prophylactically prescribe it.
Neither. All right, I'm just aware it's time. Sorry. No more questions? Yes, Joanne.
Now, I do think we definitely need to engage with our colleagues, and we do when it comes to patient management, but even beyond that, I think there is work to be done in that kind of education piece. I was fortunate enough to be invited to talk at the Australian Rheumatology Association meeting. It was in Atlanta.